good morning and salam sejahtera to everyone who's attending still for our second half of the breakfast session this morning. So we move from the cardiac rehab to all the way to the brain that's going to undergo surgery. And we've got our prominent team here for awake brain surgery. A little bit of introduction. Awake brain surgery in has actually started in 2014. Led by Associate Professor Dr. Vairavan, who will be the speaker from the neurosurgical side later, with the help and guidance of our dear Professor Lucy Chan. So they did 3 cases, and subsequently, my chief here, Dr. J. Ganesh Virakumaran, our neuroanesthetist, lead in neuroanesthesia, consultant here with me for over 10 years, have taken over, and they have successfully done 40 awake cases. Actually remarkable. So let us listen to the remarkable journey and how they have managed awake brain surgery. So I'll hand over to Dr. Jaya to start his presentation. Go ahead, Jaya.
Hey, good morning, everyone. I hope y'all can hear me.
It's loud and clear, Jaya. Very good.
In the interest of time, let's dive into our topic, right? Okay, awake brain surgery. Does all patients with brain tumor come in for awake surgery? No, right? Awake brain surgery is performed in patients who are fully or partially aware or awake at some point of time during the brain surgery, right? During this time, the patient is able to communicate with the operating team, perform certain tasks, or demonstrate a brain function, which is usually motor or language function. So we will keep communicating with the patient while the surgery is done. And for this to be successful, OLED and experienced multidisciplinary team is vital. So this is how a setup will look like when awake surgery is performed. There will be a screen barrier demarcating between the surgeon and the anesthetist with the patient awake. So what are the indications? Like I said earlier, not all patients are indicated for awake surgery. So what are the most important kind of patients that are advised for awake surgery? Number 1 is mass lesions adjacent to the eloquent areas of the brain, mainly motor or language cortex, tumors in the frontal lobe or in the occipital visual function. Gliomas, high or low grade, patients with epilepsy, vascular lesions, or sometimes patients coming in, or most patients coming in for deep brain stimulation for Parkinson's disease. So what are the benefits of awake surgery? Most important thing is preservation of the eloquent, highly functional brain areas. This also allows seizure focus localization with electrocardiography, right? And as the patient is remained awake, we avoid the risk of general anesthesia. With a patient being awake, we also reduce the risk of post-operative pain, nausea, vomiting, which is associated with general anesthesia. And this also reduces the extensive needs of monitoring patients in ICU, and therefore we reduce congestion to our ICU colleagues, and also in the long run reduced length of hospital stay and medical costs. Patients with undergoing awake craniotomy have also found to have fewer neurological deficits, which was our main aim of doing it. So not all patients that are suitable for awake craniotomy can be proceeded with awake. There are a few absolute contraindications for awake craniotomy. Number 1 is patient refusal. If the patient refuses this type of surgery, we shouldn't force a patient to it, right? Patients who are unable to lie still or flat for any sort of medical reasons, example, patients who are cardiac failure or patients with certain types of medical disease which prevent them from lying flat, and patients who are unable to cooperate due to any reasons, maybe due to the tumor itself or other related conditions. There are few relative contraindications anesthetically or surgically when patients are planned for awake craniotomy. Obese patients with difficult airway is a no-no for an anesthetic point of view. Huge and vascular tumor where we expect difficult surgery or any amount of blood loss should not be considered for awake surgeries. Tumors or patients with neurological disorders, example cognitive dementia and dysphonia, may also sometimes be a relative contraindication for awake surgery. Young patients, I highlighted this because not all pediatric patients cannot proceed with awake surgery. Some pediatric patients with a good maturity age can proceed safely for awake craniotomy. So what are the anesthetic methods that are available for us in order to do awake brain surgery? There are the three main known methods, which is the sleep, awake, asleep. Again, I highlighted this because this is the method that we use in our center, right? The patient is kept asleep, then the patient is woken up, and then the patient is kept back asleep. Some centers do asleep, awake, awake, and then other will be awake all the way. So when we say asleep, we can achieve this either by endotracheal intubation, laryngeal mask airway, or monitored care anesthesia, which we mostly use in our center will be monitored anesthesia care. What are the steps in awake brain surgery? There are three main steps that we usually follow in awake surgeries: the pre-monitoring stage, the monitoring stage, and the post-monitoring stage. What is in the pre-monitoring stage? The pre-monitoring stage is the beginning. This is where the patient is given the local anesthesia or scalp block, application of Mayfield pins clamp, skin incision, the craniotomy is done, removal of the bone flap, and opening of the dura mater. We should pay a special note in the opening of dura mater, which is sometimes associated with quite a painful stimulation. Right? Then we come to the main monitoring stage, where the patient has to be awake at this stage. And at this stage, the neurophysiologist usually does a neurophysiological monitor and motor assessment. And with this, the brain monitoring and brain mapping is done. Once the brain is mapped and monitoring and a baseline is taken, the tumor resection will commence. Once the tumor resection is completed, we get into the third phase, which is the closure. So the most important thing, I think, when we consider awake craniotomy is consent taking. We should spend some extra time talking to the patient, explaining to the patient all about the procedure before we can take a consent. Right? All the possible events must be told. We usually do a tour of the operation theater where the patient is taken to the operation theater the day before and then showed how the operation theater will look like. This is just mainly sometimes to reduce the anxiety of the patient. Right? Meeting the team. Right? The patient usually is met with the team the day before of surgery so that he's familiar with all faces and he will not get to see any new faces during the surgery. And the neurophysiologists and surgeons, we will explain all the possible monitoring, function, language testings that we are going to be monitored intraoperatively. So what are the anesthetic techniques or anesthetic agents which is ideal for awake craniotomy? As we all know, it has to be rapid onset and rapid offset, titrability, and minimal lingering effect. So what are the gold drugs that we have. Propofol, as we all know, is still one of our most commonly used drug. Fentanyl, remifentanil, our new gun, and of course dexmedetomidine, which will cause slightly lesser respiratory depression, sedation, and analgesia. Pre-operative preparation. The day before the surgery, the patient is required to fast, and just not like our usual general anesthetic patients, these patients have to be fasted for just 6 hours. We usually don't overfast our patients, as this will sometimes lead to restlessness of the patient. The case is best done in the first case in the morning when everybody is fresh, the surgeon, the anesthetist, and the patient. And usually we will ask the patient to have a good bath in the morning so that he will be fresh too and alert during the time of surgery. We usually advise the patient to empty the bladder before he's wheeled down to the theater. Intraoperative, or our pre-monitoring stage. We usually avoid excessive cannulations or lines, as each time we cannulate or we prick the patient will cause pain and agitation to the patient, right? As we ask the patient to empty the bladder before the surgery is because we will avoid CBD when possible, as insertion of CBD may cause discomfort and therefore may cause restlessness to the patient. Another important aspect to play is temperature. The OT temperature should not be too cold, as this again will cause agitation to the patient, right? Patient is allowed to continue playing his favorite game, listening to music via his earphones. This is just to keep the patient away from the surgery and distract him, right? Maintaining a minimal background sound in the operation theater is important. Everybody in the theater should not be chit-chatting or talking things that are irrelevant because this patient is awake. Maintaining good communication with patient and explaining step-by-step procedures being done sometimes in real time may be helpful. During the intraoperative or the pre-monitoring stage, we usually insert just one large cannula in the contralateral hand. We provide oxygen with a nasal cannula and a mild sedation is started. In our center, we usually use remifentanil and dexmedetomidine, which is titrated to patient response. Routine non-invasive monitoring is applied, and a BIS monitor is applied once brain navigation is completed. Skull block is then given once the patient is on table. The drug that we use commonly is plain marcaine diluted to 0.25% added with some lignocaine. Skull block, right? Skull block is very important or vital for the successful of patients coming in for awake craniotomy. Usually what we explain to patients, there will be 5 pricks with 6 nerves being blocked. What are the 6 important nerves? Are the supratrochlear nerve, supraorbital nerve, zygomatic temporal nerve, auricle temporal nerve, lesser occipital, and circumferential band of local anesthetics is given, which is also covers the greater occipital C2, C3 nerve. Okay, operation theater organization. It's a bit different compared to our routine layout when patient is under general anesthesia. As you can see, the surgeon is always at the head end of the patient with the runner and the scrub nurse beside of him. And then there will be the green drape that I showed in my first slide with the anesthetist and the neurophysiologist in the other side facing the patient. The other side would, the leg end of the patient will be our anesthetic machine, just in case we need to convert the patient into general anesthesia. And then we have all our neuro navigation system microscopes in the other side of the theater. Pin, and once the patient is applied skull block, the pin site is identified and a clamp is applied gently. When I say gently, we should always increase the pressure of the clamp slowly so that the pain will not be an excruciating pain. And during the initial phase, patient will be maintained at a slightly deeper and sedation, right? And targeted by the beast. Remifentanil is kept at minimal amount, usually around 0.3 to 0.5 nanomils. Presidex is titrated to patient response in this phase to reduce anxiety and restlessness. We use two combination of drugs of remifentanil and Presidex to reduce the risk of apnea. As we all know, Presidex has no effect on the respiratory rate. And if we keep increasing our remifentanil, we may experience a stage of apnea. So what are the challenges we have during our anesthetic pre-monitoring phase? Most common problem is agitation due to the long operation, inadequate sedation choice, and inadequate analgesia. And sometimes the patient may develop airway compromise, desaturation, or hypercapnia due to excessive sedation. So what are the useful adjuncts that we can use to help the patient? Empathy, sometimes holding the hand, reassurance of the patient may improve patient agitation. Sponging, soap, ice, water can be used to wet the patient's lip and mouth to comfort the patient, right? Patient can be allowed to move the limbs or hips at appropriate times just to keep himself comfortable. The monitoring stage. The monitoring stage, sedation is gradually reduced until a good communication is established within, and usually there must be a good communication between the surgeon and anesthetist. It usually takes about 15 minutes before we can wind down our sedation. And then the neurophysiological monitoring, language, motor, and cortical, subcortical mapping is performed. Patient must be kept comfortable during all the period of testing. Once mapping is done, resection will commence. Monitoring. During the resection, blood loss is kept as minimal. Patient is allowed to continue to hear his music or monitoring. The goal, what is our fluid management strategy? We usually use goal-directed fluid management to reduce brain edema and bladder discomfort, which may lead to restlessness. Our fluid choice is usually a balanced solution. And the post-monitoring stage, once the tuner is completed, hemostasis is maintained and closure will be done. Sedation can be increased back and patient will be allowed to sleep. During dura closure, additional supplement of local anesthesia can be applied as it may be a painful stimulus. What are the role of anesthetists in awake brain surgery? Inducing and maintaining conscious sedation, monitoring vital signs, ensuring there is no airway management, airway compromise or management, pain management, communication with patient and surgical team, addressing patient's comfort and anxiety. And we must always prepare for emergency in case we have to convert the patient into general anesthesia. Anesthetic expertise and vigilance are essential for the success and safety of patient undergoing awake craniotomy. With this, I end my presentation. I will hand over to Prof. Vairavan to continue on the surgical aspects of patients for awake craniotomy.
Thank you very much, Jaya. So the anesthetist will hand over and hear from the lead in awake brain surgery. So all yours, Prof. Vairavan.
Thanks, Huisan and Jaya. That was, I think you've already covered most of the important bits about awake brain surgery. I mean, obviously, in awake brain surgery, the anesthetist is equally important in ensuring that the patient is not asleep and is able to function along with us. So that's, and I think Jaya has covered quite a lot of that important bits. Uh, I'm just going to talk very briefly about the surgical aspects of awake brain surgery. Awake brain surgery itself has goes back to thousands of years, back to Egyptian times, and then subsequently Middle Ages, when trephination of the skull was done to release the spirits which were stuck in the brain and things like that. So actually, awake brain surgery has a very long history. The modern version of awake brain surgery, however, started about 100 years ago. Originally was Wilder Penfield and subsequently Harvey Cushing, who actually popularized the need for awake brain surgery, initially in epilepsy cases and subsequently in eloquent brain tumor cases. And this is what awake brain surgery environment looks like now. There's so many technological advances that actually helps us ensure the surgery goes well and the patient is comes out of the surgery reasonably with good outcomes. I think Jaya has covered this, but to reiterate, the main indication of awake brain surgery is for intraaxial lesions which are adjacent to or involved in eloquent brain areas. And we want to preserve these eloquent areas. And that's why an awake surgery actually helps us maintain this. The main goal of awake surgery is to maximize tumor resection or lesion resection while preserving neurological function. And it is very clear that awake brain surgery is able to allow for more extensive resection. It reduces the need for post-operative intensive care monitoring. Most of our patients post-operatively are able to actually sit up and walk out of theater if needed. And their recovery is much faster compared to standard patients under anesthesia. The cost is also less because obviously we're not using as much general anesthesia, general anesthetic medications. This is a proven fact that there is fewer neurological deficits among awake brain surgery compared to asleep patients. In fact, the difference is quite vast, 7% in awake surgeries compared to 23%. Obviously, due to the fact that we are able to monitor the functional deficits in real time and able to minimize it. Hospital stay as well is much shorter. One of the main reasons for hospital stay is the patient has got all the neurophysiological changes due to general anesthesia, and this is averted in awake brain surgery, and thereby patients are able to mobilize earlier and able to go home earlier if needed. The longer survival is an indirect benefit of brain surgery in that we are able to resect more extensive tumor areas and thereby reduce the tumor burden, which we need to cover with adjuvant therapy later. There's also a lesser need for intraoperative vasopressors, less pain, less narcotic usage, and reduced post-operative nausea and vomiting, as Jaya mentioned earlier. The patient acceptance and post-operative satisfaction has been shown to be much is very acceptable. Post-traumatic stress disorder, despite the fact that we are all worried about it, it is not very common. In fact, in all our 40-odd patients, we've not even seen one post-traumatic stress disorder. The physiological disturbance obviously is minimized. However, up to 30% of patients do report considerable intraoperative pain. And up to 14% do have significant pre- and intraoperative anxiety. And this does need to be taken care of in a very safe and conscientious and empathic manner, because we can't just push ahead with these kind of surgeries when the patient is awake and he or she is having serious anxiety on table. And those are the kind of cases we sometimes do consider if the anxiety is not reduced to convert to general anesthesia. One of the most important aspects of pre-surgical planning, as Jaya mentioned, is counseling. A patient must be informed of every step of the surgery, from position to the craniotomy, noises and vibration, to CBD insertion if necessary. They must meet the whole team, preferably 1 to 2 days before surgery, if not earlier. They need to meet the surgeon, not just the surgeon, they need to meet the assistant, the anesthetist, the neuropsychologist who's going to be doing the test. All of this must be done pre-operatively, not on the day of surgery, not on the morning of surgery. And one of the things we practice here, Jaya has done quite well, is OT and recovery room visits. So the patient is actually taken on a tour of the OT facilities, where he'll be lying down, where the recovery process will happen, where the anesthetic scalp blocks will be given. All of this is actually demonstrated to the patient the day before surgery, and this reduces the anxiety during the procedure itself. Jay has covered the anesthetic technique, so I will not go much into that. Moving on, again, the operating theatre ergonomics, very, very important. It is essential that we plan this pre-operatively so that everybody knows where they have to stand, they minimize the movement, they minimize the noise, and patient knows that we actually have everything under control. The anxiety of the patient actually increases when they see a lot of movement, a lot of talking, and a lot of confusion. So all of this, it is essential that we plan this and avoid any of this from happening intraoperatively. As this slide shows, there is multiple monitoring going on in a operative awake brain surgery patient at the same time. We've got everything from the anesthetic monitors to the surgical navigation system, microscopes, the various neuropsychological monitoring, as well as the task displays. So all of this has to be integrated into a coherent information stream that is then converted to actionable information that we can use to optimize the surgical resection itself. Here, I'm trying to show the eloquent areas we commonly are worried about. So in this case, this is the language areas. And as you can see, they are actually, the traditional teaching talks to us about Broca's area and Wernicke's area. But we have moved away from the traditional teaching. We do have now an anterior language area, which is somewhere in the posterior frontal region, as well as a posterior language area, which is somewhere in the middle part of the brain. And more importantly, what the current knowledge actually tells us is it's not just the language areas, it's also the connection in between both areas, the arcuate fasciculus, the language tracts. And just preserving the two anterior and posterior language area alone is inadequate. We need to preserve the actual tracks that connect both of this. And that's why language monitoring has become even more advanced, developed, and we can minimize any incidental deficits in these patients, especially when they are being done awake. This is a motor homunculus, which shows the similar functional areas for motor, both on the right and left side distributed. This is something familiar for most medical students, so I won't go into that. What about the physiological tests, the motor and sensory pathways? So the asleep mapping, we will do a motor evoked potential as well as a sensory evoked potentials. And these patients would usually have monitoring needles in the face, usually around the lip area, sometimes very rarely in the eyes. They would also have needles in the hand and leg. And usually this is on the opposite side of the surgical area. Usually the patients would have some feeling of electricity running through their muscles, as well as flicker of the muscle during stimulation. As opposed to awake mapping, we can actually do motor mapping in awake without any of these electrical assessments. This is usually by voluntary movement of the arm, fingers, legs, etc. And we are looking for movement arrest in a positive motor area. This is what a neurophysiological monitoring looks like. One of the reasons we are able to develop our awake surgery so extensively in the last few years is because neurophysiological monitoring, especially in UM, has actually expanded and has gained a lot of experience, and they are able to help us monitor everything from the motor strips through a phase reversal to actual white matter monitoring through subcortical electrodes. So these are essential components of doing successful awake brain surgery. I'll very briefly show a simple video of a voluntary motor movement. So this is our neuropsychologist actually asking the patient to move his arm and his leg while I'm actually operating on the other side of the screen. Moving on. This was the tumor we were operating on, just briefly to show you. So what we're seeing here is the motor strip, the motor strip as well as the tumor. And we would like to, in this case, avoid the motor strip. This is the motor strip. And you can see right in front, anterior to the motor strip, is the whitish area. That's the bulk of the tumor. And we are now trying to remove the tumor while not endangering either the motor strip or the sylvian fissure. This is the sylvian fissure, which all contains eloquent areas. This is what the brain would look like when we're doing the surgery itself. We would start looking at the cortical areas and mapping them out, putting numbers onto them to describe which ones are the eloquent language areas, the motor areas, and the various different areas. I'll skip through due to our short time. So these are the main language testing we would do. We have various, we used to use picture cards, and now we've moved on to iPads with a fixed number of pictures, which we will use for language assessment, especially for generation of words, for memory, etc. This is a very short video which explains the one of my trainees helping us assess a language in Mandarin with this patient. Because his primary language is in Mandarin, we are assessing the actual language assessment through his primary language. Skip this as well. We can also assess visual mapping with various different neurophysiological adjuncts. And this has actually helped us with visual cortex tumors as well. Do we need any special equipment during surgery? There are drapes. We will need the microscope and image guidance. But the more essential one is the human resources. We need the intraoperative neuromonitoring team. We need a neuropsychologist who is able to help us with this. We need a good anesthetist who understands how to keep the patient sedated enough, but not too sedated that they are unable to cooperate with us. So there are various challenges during awake. Seizures is one important one. We do have patients who will develop, due to the simulation, electrical simulation directly onto the cortex of the brain, patients can develop seizures, and this has to be minimized. We do have adjuncts that will help us reduce the seizures, everything from anesthetic adjuncts to ice cold water, which works very well onto the brain directly. We also have got patients who occasionally can develop agitation, delirium. Most of the time, compassion, speaking to them, holding their hands, as Jaya said and has demonstrated in my cases before, it really helps. We do have occasional patients who sleep very quickly with even the lightest sedation, and they have a lot of difficulty waking up to actually continue with their awake phase. So that is a problem we have faced occasionally. Nausea and vomiting, not very common, especially with the modern era of anesthetic drugs. Hypothermia, this is common. And one of the things Jaya usually does is increase the OT temperature as well as put the patient on a warming blanket. We ensure the comfort of the patient throughout the surgery as much as possible. So awake brain surgery is actually only successful if the team is able to work together properly. So it has to ensure, the team has to ensure patient safety, collaborative decision making, minimize the stress and anxiety, and optimize patient outcome. And to ensure this, we need to have a surgeon, an anesthetist, a neurophysiologist, a neuropsychologist, nursing assistant, as well as the various non-operating assistants, all working together as a cohesive unit. And that is the only way we can ensure the best patient outcome. With that, I finish my talk. Thank you very much.
Yeah, thank you very much for the exciting topic and both your presentations. Very good. Now, I think we should have been given 1 whole hour. Actually, there's a lot more to discuss and see. But a good overview. And we've got several questions actually to my team here. I think the first one from Prof. YK highlights anxious patients' anxiety. And I think for the public and also your patients, the Hollywood movies does not help. When they have painted a very scary and fearful experience of awake craniotomy. So her question is, how do you communicate if how do the patients communicate? Okay, so we'll start with the first one actually, where the patient is already on the table and suddenly develops anxiety. So how does a patient communicate and how can it be managed? So this patient is already on table.
Yeah. I'll let you take.
So either one of you?
Okay, once the patient is on table and the patient is feeling anxious, I think communication is important. We should ask the patient why is he anxious or agitated. Sometimes it will be the position, right? Maybe the position is not too comfortable for him. Maybe it's too cold operation theater. I had cases where sometimes the patient's leg is out of the bear hugger or the warming blanket, so the legs feels cool, right? So I think communication is vital. So we should ask the patient what is wrong and treat the cause. And if all that we are already done and the patient is still anxious, communicate with the surgeon, ask whether it's anything related with the brain. If with all that is done and still anxious, then maybe we can slightly increase our sedation, guided this.
Yeah.
But I think most of the time there will be a cause for this restlessness or agitation.
I applaud my neuroanesthetist. Jaya is a very calming neuroanesthetist, and that's what Varavan will be very happy with. I don't know. You have to calm the patient down and ask what is the reason. But let's rewind the process a little bit. Let's say pre-operatively in patient selection. I know patient selection has to be very important. And like I said, a lot of them will start off with a huge fear factor, just telling them that, you know, your surgery, one, you've got a tumor, and secondly, we are operating on your tumor while you are awake. So, Prof. Iravan, how would you then break the news, the plan and the flow of progress to your patients until they say, yes, I consent to an awake craniotomy?
These patients are actually counseled in the clinic when we first see them. And usually, as I said, awakes now, I reserve them for primarily for language areas as well as areas where I cannot monitor while they are asleep. So while previously, when I first started, we used to do motor mapping as well. Nowadays, motor mapping is done asleep because our neurophysiological monitoring has advanced so much that we can do them asleep. We can get as good results as sleep. So these language patients, though, we do counsel them from the beginning. We tell them, look, at the end of the day, we want to take out as much tumor as possible with as minimal complication as possible. And you have to convince them that you have done enough of these cases, that they have been successful. We have got a good and experienced team who are going to help you through this. At the end of the day, it all comes back to the confidence you portray to your own patients, as well as the confidence they have in you. So it's a two-way communication, and that it starts with that. Of course, as Jay has mentioned, and I mentioned as well, we bring the patient in early, and we actually sit down, talk to them. We introduce the whole team to them, and subsequently the patient is actually taken down to theater. All of this actually makes the patient much more calmer, because they feel like, okay, I know what is going to happen to me step by step. I know who's going to touch me. You cannot have somebody getting the consent and then a third person suddenly turns up to put the needles in or do the scalp block or whatever. That is absolutely not acceptable in any surgery, especially in awake brain surgery. So these are the things we do to minimize the anxiety as well as the necessity for conversion in our patients.
Yep, I agree. There's a lot of rapport to be built and get the patient to know the environment and people. There's another question by Prof. YK for Jaya about putting in a laryngeal mask airway, and I presume she's asking the final stage 3, and is the laryngeal mask removed at the period of evaluation?
Yes, like I mentioned in one of my slides, there are a few methods that we can keep the patient asleep during the initial part of the surgery. So one of them is actually laryngeal mask airway. Actually, I have in our center we keep them in monitored care sedation, but I've seen in another center in KL where the neuroanesthetist actually fits in the laryngeal mask airway, and then at the time of monitoring, he actually gently removes the laryngeal mask airway. The time of removal of laryngeal mask airway has to be very gentle and accurate, because we can't afford to have the patient coughing or barking during this time. So usually the laryngeal mask airway is extubated while the patient is still on remifentanil. So I mean, I personally sometimes find it a bit stressful too, putting in a laryngeal mask airway and removing the laryngeal mask airway, and then putting back again during the last part the laryngeal mask airway. So I opt for the safer way of monitored care sedation for my awake craniotomies.
So yours will be fully deep sedation or light
I
sedation
use
type of variation.
I use Presidex and remifentanil. In some centers also, they use propofol. But what I find when we use propofol and remifentanil, there is synergistic effect and a higher risk of patient going into apnea. So I choose Presidex as my alternative, because I know Presidex doesn't cause respiratory depression. So if at all my patient gets into respiratory depression or apnea, I know the culprit must be the remifentanil.
Yeah. I think bear in mind what Jaya says, when if patient accidentally coughs and there's movement, the skull is actually pinned. So I think that's not only a little anxiety on our part, I think that's very nerve-wracking as the anesthetist watching the airway. Perhaps Varavan can answer the question by Prof. YK. After resection, what are the assessments to determine if the whole tumor is out?
So most of the time we do know when the whole tumor is out. But there are occasions where we don't know, especially when it's a low-grade gliomas or very diffuse tumors. And again, in pediatric tumors as well. So in those cases, we do have an adjunct that helps us, primarily the intraoperative MRI. I think we are one of the few centers in the, not just the region, in the world, which does intraoperative MRI for awake brain surgery. So we would do the patient awake brain surgery. Previously, when we first started the intraoperative MRI, we used to tube the patient and then do the intraoperative MRI and extubate them if necessary. Nowadays, we actually, the sedation and the monitoring is good enough that we can actually push the patient in without intubating. So throughout the whole process, the patient is awake, the patient actually goes into the MRI, we do the MRI, when they come out. The MRI is the gold standard for completion of tumor resection. And that helps us determine, do I need to do additional resection or should I stop there, and things like that. So we use the intraoperative MRI as our primary gold standard for completion of tumor resection.
All right. We have reached 9:16, and some of our participants have also dropped out because of the timing. But I think it was really, really good. We took 45 minutes though. It's actually a big topic, and I think it should have been given a whole hour. So the last bit, I want to thank the two fantastic speakers and all the audience and all the questions posted. I think we've answered and covered most of it. Last bit, the primary rule for success given by the lead in awake craniotomy, Varavan, is actually teamwork, understanding, and communication among all the anesthetists, surgeon, neurophysiologist, and nursing staff. And I think to top it all, I can hear the ringing word of a calming environment. I think that's really, really important. We are very used to patients who are already under general anesthesia, but these patients are fully awake, can hear us, fully conscious. So a calming environment, I think it is the pepper or salt for the success of this team. All right, so thank you very much to everyone who has joined us. It has been a very, very good CME session or breakfast session with great speakers and a good discussion. So everyone have a good day.
Thank you.
Bye-bye.
Thank you.